Rounds, everyone. So as usual, I always start at 8:01, and I always start with a thank you for all of you for attending our grand rounds and coming to learn something new and important about medicine. And it is the end of April, and we are going to get 6 to 8 inches of snow tomorrow. So I just want a little reality check for everyone here. And Dr. Roy, thankfully, is going to be leaving before the snowstorm starts. So with that, I would like to tell everyone again, we have a series of speakers who are called the Dream Speakers. And the Dream Speakers are people that are chosen individually by our chief residents because of an area of expertise they hold that is the interest of our chief residents or someone that they've interacted with in their life that is important to them. This particular Dream Speaker is sponsored by Dr. Brian Lewis. Brian, you want to wave to all of us? Yes. Thank you. And so our speaker today is Dr. Lipi Roy, MD, MPH. She is a clinical assistant professor at NYU Langone Health. Her talk is entitled Battle Behind Bars, Addiction, Incarceration, and Evidence-Based Treatment. And we met this morning. We were just talking a little bit before Grand Rounds. She's going to talk about this, but this is an area of addiction medicine that's really quite new, that we haven't really paid a lot of attention to in medicine for many years, and is an area that some of us really don't learn about in residency. So I think this is going to be critically important to hear her message today. She received her combined MD, MPH degree from Tulane University in New Orleans. She then went on and did her residency and internship at Duke University in Durham, North Carolina. She currently holds a dual appointment. She is a clinical assistant professor in the Department of Population Health at NYU School of Medicine, as well as a clinical assistant professor in the Division of General Internal Medicine at Massachusetts General Hospital. She holds several leadership positions, which I think are of importance very early in her career. She is the medical director for the Kingsborough Addiction Treatment Center for the New York State Office of Alcoholism and Substance Abuse. She is also the chief of addiction medicine for correctional health services at New York City Health and Hospitals. I'm always interested in the kind of honors that people have received in their career, and I want to highlight one of the honors that she received in 2016, which I think speaks to the work that she does and really walking the walk. She received the Dean's Community Service Award from Harvard Medical School, and this was for dedication and commitment to the health of Boston's homeless men and women. So with that, Dr. Roy, please come on up.
You're welcome. All right, so make sure that my thing is on here. All right. Can you guys hear me? Sometimes I like to walk around a little bit. First of all, thank you so much, Dr. Trowbridge, for that wonderful introduction. Before I start, I know people are trickling in, but can I get a show of hands? How many of you are medical students? Small smattering, okay, one or a couple. All right, how many of you are interns in the Department of Medicine? Okay, a couple. The rest are probably on the floors, getting all the vitals and whatnot, and labs and checking out potassium. All right, second year residents? All right, and third year residents, medicine, okay. Any fellows? No? Oh, fantastic, that's great. Okay, this is great. I just want, we have medical students. I've been practicing for about a decade now, but let me tell you, I remember residency like it was yesterday. That could be good and bad, but I remember what it's like. There are good days, there are bad days, particularly intern year. For me, intern year just happened to be the hardest year of my life. I don't think that's foreign to a lot of you who've been through intern year or residency in general. It's a rite of passage, but I just want to share one philosophy when it comes to making mistakes. We all make them. We all will continue making them. Even as an attending, it never stops. But something gets amplified when you're an intern, and you're getting paged nonstop. You have so many patients to take care of who are so sick. You got to talk to family members. The nurses are paging you. Your attending is expecting you. Mistakes are common, but this is something that I've learned, and I thought I'd share with you. When mistakes happen, and when you make them, acknowledge it, learn from it, and then move on. So many times we just get so bogged down with what we did wrong, and we just can't move forward from there. But let me just say, I'm so grateful to be here. Thank you, Dr. Brian Lewis, for the kind invitation. I'm so honored to be here. And you'll soon discover that everything that I'm going to talk to you about today has been from on-the-job training. As Dr. Turbin mentioned, I went to some nice schools. I was very privileged to attend some wonderful medical schools and training programs, but topics like addiction, certainly correctional medicine, they don't teach you that. They just don't teach you that. And pain and other related topics. So I was very fortunate to learn a lot of these things on the way, and I believe it's my responsibility to share what I know with all of you. So I'm actually the former chief of addiction medicine and the first chief of addiction medicine at Rikers Island. I now work at an addiction treatment center in a Brooklyn-based addiction treatment center. So I previously consulted for an advertising agency called Rescue, and I did some training for a media institute called the Pointer Institute. So one of the things I like about events like this is that it brings, obviously, the academic learning, but it also brings people together. So I don't need to tell you where Madison is. I probably also don't need to tell you that one of my former colleagues, when I was at Mass General Hospital, when he found out that I was coming to Madison, this was a couple years ago when I first came to Wisconsin, and he said, "Oh, Lipi, you gotta visit the Mustard Museum." And I'm like, I'm sorry? He said, no, you gotta go. And sure enough, I went, and I actually really liked it. Who knew there were so many types of mustard? And of course, I'm sure there are some Green Bay Packers fans here, right? So when it comes to sports, speaking of which, even though I currently live and work in New York City, I'm actually from Toronto, born and raised Torontonian. And when it comes to sports, well, sometimes stereotypes exist for a reason. So what would you say is my favorite sport? Hello, yeah, hockey. And if anyone follows hockey, you might know what happened to my Maple Leafs. They got eliminated by the Boston Bruins just 2 nights ago in the playoffs, but that's okay. I thought I'd still come here and not just lie in bed and cry. And, of course, the other stereotypes about Canadians, maple syrup. Well, who doesn't love maple syrup? All right. So let me just get into some of the objectives for today that I'm hoping to convey to you. To understand that addiction is a chronic medical disease of the brain. Recognize some treatment strategies for opioid use disorder, including medications and behavioral therapies. To identify the impact of addiction in the incarcerated population, and to recognize the role of stigma as a barrier to care. So let me introduce you to somebody who was very important to me. I first met Brian when I was a primary care doctor to Boston's homeless population. Frustrated, depressed, and experiencing severe neck, shoulder, and back pain, Brian had enough. He said, "Dr. Roy, I just can't take it anymore." So in addition to his chronic medical and psychiatric issues, Brian had also just lost his job and lost custody of his son, which drove him into deeper depression. Ashamed but desperate, Brian started to use heroin to numb his pain and suffering, and he just couldn't stop. Sadly, Brian's story is not unique. It turns out, in 2013, we found data from our organization, Boston Healthcare for the Homeless Program, showed that the leading cause of death amongst Boston's homeless population was drug overdose. So today we hear about drug overdose deaths all the time. Back in 2013, we weren't really seeing the daily headlines that we're seeing now. But that information completely transformed the way that I provided care. And so more about that and Brian's journey as we move along. So a brief outline of what I hope to talk about: incarceration, addiction, the opioid epidemic, the incarcerated population, correctional medicine, opioid addiction treatment at Rikers, stigma, harm reduction, racial disparities, and hopefully some really helpful resources for all of you. So again, I didn't learn any of this until I really started working at Rikers Island. The United States is great in many, many ways. This is one area where it's number one, and it's an area where we should be ashamed that we're number one. The United States leads incarceration rates globally by not a small margin at all. And so that really translates to over 2 million people in prison or jail, resulting in over 500% increase over the last 4 decades. So how did mass incarceration happen? U.S. law enforcement started arresting and incarcerating people in an attempt to be tough on crime and fight the war on drugs. So if you look at the gray bars are basically incarceration in 1980, state prisons, federal, and then jails. And then 2015, an exponential rise in incarceration rates. But you know what? There's actually a lot of collateral consequences as a result of incarceration. Some of them, and just a small handful, include the fact that 1 in 50 children in the United States has a parent in prison. In addition, 6 million Americans are not allowed to vote due to felony conviction. Now, I just spoke in Baltimore. That is the entire population of Maryland. Some things to keep in mind. So I think we've all seen some of these headlines. Prince dying of overdose. Whitney Houston. Heath Ledger, who was only 27. Philip Seymour Hoffman. How many people know this Academy Award-winning actor? He was one of my favorite actors. He was actually in recovery for 20 years. And then something happened in 2014. He suffered a relapse, experienced a relapse, and he was found alone in his Manhattan apartment, surrounded by drug paraphernalia, found in a fatal overdose. And of course, even if you go trace back several decades, Janis Joplin, and then Judy Garland. And then more recently, Tom Petty. Nobody suspected Tom Petty to be using drugs. So when I wrote an article about this in Stat, not last year, the year before, it got a lot of attention. It had nothing to do with me. It had to do with the fact that this legend, this music legend, died of something that good people aren't supposed to be dying of. And then more recently, last summer, Demi Lovato, and thankfully Miss Lovato is still alive, and she's in recovery, but it's an ongoing struggle, and we'll talk about that. But as we all know, addiction doesn't just impact the rich and the famous. We've all seen these local, state, and national headlines. Overdose killer drugs next door. Mother of Capitol Hill overdose victim. There's no way to describe this grief. And then right here in Wisconsin, opioid crisis affecting Wisconsin companies. And then we started to see some evidence of intervention. The New England governors converged to address the opioid epidemic. On the federal level, Obama's administration passed CARA, the federal act. And then more recently, our current administration declared it as a public health emergency. So, drug overdose. We all know this is impacting the entire nation. So this was the landscape of the country back in 1999. The red areas indicating overdose deaths per 100,000. And then a mere 15 years later, this is the landscape of the country. So, and I'm sad to tell you, ladies and gentlemen, this is way back 5 years ago, 4.5 years ago. Today, easily 70% of this map would be bright red. And translating to, essentially, according to the CDC, 72,000 deaths, mostly driven by opioids. In terms of numerical value, this would have been 16,000, about 40,000, and now 72,000. And we've also seen, I'm sure, the CDC data showing that drug overdose deaths not only have overtaken traffic accidents, but also gun homicides. Don't let anybody tell you that this is not a public health crisis. And now, if there's any positive about the current opioid crisis, it's that it's shining a spotlight on addiction more broadly, and which is why I really am grateful to be discussing this topic. So a little bit about the origins of the opioid epidemic. So how did we get here? How many people have heard of Purdue Pharma? Yeah, I think 99% of hands went up. So they are a privately owned company, owned by the Sackler family, and Purdue introduced OxyContin in the 90s. They also funded over 20,000 pain-related educational programs in the late 90s, including providing financial backing to the American Pain Society, which came up with the Pain is the Fifth Vital Sign campaign, and they funded an organization that directly impacts all of us, which is JACO, or the Joint Commission. Of note, I don't need to tell this group that JACO accredits hospitals and physicians and patient groups. So of note, in 2007, Purdue and its executives were fined over $600 million for deliberately misleading patients and physicians and other governing bodies of OxyContin's addictive qualities. And you might think, wow, Libby, $600 million, that's a lot of money. You know what happened? It turns out that between 2008 and 2016, the Sackler family paid itself over $4 billion just from the sales of OxyContin. So there are consequences to actions. So also, though, it's also a question of good intentions gone wrong. Doctors clearly played a role. In the late 90s, doctors were pressured to address this pain as the fifth vital sign. By the way, there has never been a pain crisis. Pain levels, studies show, have remained constant. How we were told to treat it is what changed, right? The messaging or the narrative. And that happened because of a particular company. So doctors were told two facts. One was that opioids are not addictive, and we were told that treating chronic pain long-term with opioids is evidence-based. And both points are patently false. Now, clearly, there were some bad apples, some doctors who took advantage of the financial benefits and reaped awards, but really they are the minority. Media likes to write stories about doctors because that's sexy, it's sensational, but they were the minority. The truth is that most doctors, myself included, learned very little about pain management during medical training and almost nothing about addiction. So again, almost everything that I'm talking to you about today has been from on-the-job training. And we are trying to change this so that more medical curricula and residency training curricula are incorporating some formal addiction training. So I want to make sure that we're all clear in terms of what the actual definition of addiction is, which is that it's a chronic medical disease of the brain, a relapsing and remitting disease that causes compulsive drug seeking and use despite the harmful consequences to the person using and to those around him or her. It is not a sign of moral weakness or failure. Now, while the initial decision to use might be voluntary, the changes that happen in the brain over time really impair that person's ability to control their drug use. So in med school and in residency, we're just bombarded with information, and so we come up with mnemonics. So think of the 4 C's. What are some words you can think of that start with C that are associated with addiction? Oh, I heard cravings. What else? Compulsive. You guys are great. What else? That's half right there, so you guys already passed. So yeah, 4 C's of addiction. Impaired control, compulsive use, continued use, cravings. So when you think of addiction, think of the primary symptom being cravings. So if somebody comes into the ER, the ED, and they have COPD, their primary symptom will probably be severe shortness of breath. If somebody is having an MI, it might be chest pain. In addiction, cravings can be so intense, it's what drives behaviors that a person who wasn't addicted would never otherwise participate in. Stealing from your grandmother, selling your body, robbing a bank or store. So, I want to make the case that the true causes of addiction aren't what you might think. We think of many different types of addiction, right? We think of substances, obviously, tobacco, alcohol, other drugs. Then there's behaviors, such as gambling, smartphone devices. I have 3 of them. Bread. Who doesn't like bread? Oprah. And then what about caffeine? Coffee. How many have already had? And it's what, 8, 20? How many have already had 1, 3 cups already? And of course, sweets. I mean, that's probably my vice, right? I love chocolate and donuts and sweets. But I'm going to make the case that it's not these substances or behaviors that are the cause of addiction. The true cause is, for the most part, it's when we experience something that's stressful, that's traumatizing, that's tragic. It could be unemployment. It could be divorce, death of a child or a family member, illness, sexual or physical assault, neglect. All of these events cause complex emotions such as isolation, grief, anger, frustration. Genetics also plays a role, but when we don't live in a society or an environment where those stressors and those emotions are taken care of, we self-medicate that pain and suffering. Addiction is nothing new, ladies and gentlemen. We're talking about the opioid crisis now because that just happens to be the drug or the substance of the day. But addiction is nothing new. And for as long as human beings, when I first got the job as chief of addiction medicine at Rikers, one of the executive district attorneys in Manhattan said to me, because we attended these monthly meetings of all stakeholders in the city, and he said, "Oh, Dr. Roy, I'm so glad you're here. You're going to help us fix addiction. You're going to help us cure addiction." And I get it, he's a lawyer, he's not a doctor, but even nothing against lawyers. But truth be told, I said to him, I appreciate that you say that. I'm going to help in every way I can, but the reality is that for as long as human beings exist, pain and suffering will exist. And for as long as pain and suffering exists, people will find a way to self-medicate that pain and suffering until we live in a society that has a perfect healthcare system, social services, there's no homelessness, there's no domestic violence. I just don't, as optimistic as I am, I can't see that society happening anytime soon. So the neurobiology of addiction is well established. Let me highlight 3 particular parts of the brain that are involved. So the basal ganglia is part of the brain that's involved with motivation, reward, pleasure, dopamine, the pleasure neurotransmitter, habits, and learning behavior. The amygdala, amygdala is part of the brain that's, think of like fight or flight, right? It's also associated with negative emotions like anxiety and irritability. And then there's the prefrontal cortex. So that's the front part of the brain that's involved with executive decision making, time management. And think about it. Before you came to Grand Rounds this morning, you woke up, turned off your alarm clock, picked out what to wear, might have picked out breakfast, might have packed a lunch, might have checked your phone, and you're thinking, yeah, Lipi, that's just common sense. I do that off the back of my hand. But think about all of the decisions that your brain made in the fraction of a few seconds, maybe a couple minutes. Now try making those decisions with substances on board, impairing the prefrontal cortex and other parts of the brain. These are the 3 stages. One is a person consumes an intoxicating substance and experiences the rewarding, pleasurable effects. You've had 1 or 2 glasses of wine, it's a nice warm buzz. And then a person experiences a negative emotional state when they're not using. Think about when you haven't had that cup of coffee yet. Like my mom hasn't had her tea or coffee. You're a little irritable, right? And then the 3rd stage. Person seeks a substance after a period of abstinence. Think about that example of Seymour Hoffman in recovery for 20 years. And then something happened. A series of things happened. So the brain remembers. Again, that's not a defect or a fault. That's the nature of the disease of addiction. And by the way, when we think of relapse, certainly whenever I used to think of relapse, I associate with addiction. But truth is that every chronic disease is associated with addiction. And in fact, relapse rates are even higher with high blood pressure and asthma than they are for drug addiction. But we just don't associate people with diabetes and heart disease and high blood pressure as relapsing. Because we tend not to stigmatize those diseases the way we do with addiction. So let me share a little bit of what I've learned about men and women that are incarcerated. Everything that I knew about Rikers, I learned from years and years and years of watching Law and Order. In fact, they didn't teach me this stuff in med school or residency. So I just thought that, oh wow, well, DA Jack McCoy is just going to come in and save the day. In fact, I had my interview at Rikers Island, and the whole time the theme song, dun, 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 and I'm like, oh, look, concentrate. But let me tell you, ladies and gentlemen, Rikers Island and most jails and prisons are nothing like what you see on television. And in fact, so not only is there not going to be a DA Jack McCoy who comes in and saves the day, A, B, if you weren't traumatized beforehand, before you got to jail or prison, you sure as hell be once you get there. Whether you're behind, or no matter what side of the bar you're on. Because I came to learn that the correction officers, many of them grew up in the same neighborhoods as those that were behind the bars. So a little bit about just correctional medicine. People that are behind bars face a lot of the same medical problems as the people you're taking care of on the floors here. But there's a high burden of disease among men and women behind bars. In fact, they are disproportionately impacted by a lot of these illnesses that I'll show you. So infectious diseases, HIV/AIDS, staph, a lot of STDs, TB, tuberculosis, hepatitis. And then they have the same chronic diseases as all of you do, as all of you treat. Some of you might have as well. And then women's health. So women, in addition to having all of these issues, also have high rates of trauma history, many from childhood, domestic violence, actually over 50%, and they have higher rates of substance use, PTSD, and suicidality versus their male counterparts. And then, of course, mental illness and substance use disorders. High rates of depression, anxiety, personality disorders, and then addiction to several substances. In fact, substance use disorders affect over 50% of the incarcerated population. So, make no mistake that correctional facilities are addiction facilities. The largest addiction facilities in this country are correctional facilities. By the way, they're also the largest mental health facilities. That says a lot about the way our society is structured. So, substance use disorder, the rising rates is having a huge impact on correctional facilities. Opioid use disorder affects a quarter of recent arrestees, placing them at risk for dangerous withdrawal symptoms. And this is just a small constellation of symptoms. Nausea, vomiting, diarrhea, abdominal pain, actually diffuse pain, severe sweats, and then irritability, anxiety, increased suicidality. The vast majority of people in this country that go behind bars that have addiction, they have to suffer with this cold turkey. Just cold, miserable. And if you ask me, this is clearly a human rights violation. We know how to treat this, and most places just don't. So, just a couple more interesting facts that I thought were really interesting. About 20% of those arrested in New York City test positive for opioids. Over 2/3 of people entering New York City jails report a history of illicit drug use. As I mentioned before, substance use affects over 50% of people entering Rikers. And from 2011 to 2016, about 30,000 people were diagnosed with active opiate use disorder. A key point here. Mortality rate is the highest in the first 2 weeks post-release, almost exclusively because of drug overdose. So this is really an excellent paper by Ingrid Binswanger, and looking at, she's out on the West Coast, showing that overdose deaths are highest in the first 2 weeks. And this is looking at people out, men and women incarcerated in the state of Washington. So this makes a strong case for opioid agonist therapy during incarceration. So evidence-based treatment exists, medications, behavioral therapies, and yet, despite this efficacy and years of decades of data, MAT is underutilized or completely unavailable in the vast majority of U.S. jails and prisons. Only 2% of U.S. jails provide access to methadone or buprenorphine, and then it's just for detox. And about half of prisons, a little under half, provide methadone, and even then it's just for women who are pregnant to protect the fetus. Because once a woman gives birth, they stop the methadone, but the woman still has the disease. Most correctional facilities opt for drug-free detox and treatment. In other words, just go cold turkey, which is not only less effective, it's actually far more harmful than just giving them medications. There is a strong misperception among the criminal justice system that these medications just substitute one addiction for another. It's a myth, and I'll talk more about that eventually. I also want to make sure that we're all very mindful of the intersection of race and incarceration. So the lifetime likelihood of imprisonment of U.S. residents born in 2001. If you're a white man, it's 1 in 17. If you're a Latino man, it's 1 in 6. But if you're a black baby boy born in this country, your chance of touching the criminal justice system is 1 in 3. The total numbers for women are lower, but the trend is still the same. For women, white women is about 1 in 100. For Latino women, 1 in 45. but black women it's 1 in 18. I find this egregious and unacceptable. I also want to share the intersection of race, incarceration, and drug use. Black Americans make up 13% of the US population, about 14% of drug users, but over 50% of people incarcerated for drug-related crimes. So I didn't know any of this until I really started working in the correctional justice system. And I don't expect any of us to solve this problem here and now, but I do want and wish all of us to be mindful of the next time we turn on the television, the next time we read an article and see, oh, it's yet another black kid being arrested who got shot. Please just think about the backstory of what led to that. So the clinical rationale for medications in corrections. Mortality reduction during incarceration, over 70%. Mortality reduction after they're released. These are all some great Australian studies. And by the way, every slide has references below. Reduction in recidivism and a reduction in HIV risk behavior. A little bit about methadone. This is a great study from Ball and Ross in the early 90s. So the pink bars are crime rates, all right, before getting methadone. After 6 months of methadone, I don't think I need to really hammer down this point anymore. The graph says it all. Significant reduction in people receiving this life-saving medication. So, speaking of treatment, how do we treat opioid addiction? This is not a mystery, all right? Last year I wrote it wasn't an op-ed, it was a letter to the editor of the New York Times, and the editor actually just wrote the title, Treatment of Opioid Addiction is Not a Mystery. You just got to be that blunt because there's just so much stigma. So 2 broad categories. There's the medications, pharmacotherapy, and then psychosocial interventions. We have the most data to support methadone and buprenorphine. We're getting some data now to support naltrexone. So the medication, oh, by the way, I know you might have seen the acronym or MAT standing for medication-assisted treatment. So even that is stigmatizing. These medications aren't assisting anything. These are medications for addiction treatment, or just call them medications, or just call them treatment. Insulin isn't assisting anything, right? Metformin is not assisting their treatment. So, and in case you might think, oh, Lipi's just pushing these meds on us, this is not my opinion. This is really well-established data, and in fact, several national agencies have supported these medications. The Surgeon General's report in 2016, well-supported scientific evidence shows that medications can be effective in treating serious substance use disorders, but they're underused. The American Society of Addiction Medicine lists all 3 medications and provides intense training and workshops all around the country. And then, this is hot off the press, just a month ago, the National Academies of Sciences, Engineering, and Medicine released a report on March 20th. Medications to treat opioid addiction are effective and save lives, but barriers prevent broad access and use. So, methadone. What is it and how does it work? It's a medication that's similar to morphine, similar to heroin. It binds the same receptor. It's used in maintenance programs to treat people addicted to heroin and other opioids. It's also used to reduce pain. So how does it work? So it's a full agonist. It's the red line up here that binds the opioid receptor. Before I even said that, the moment I said that it binds the same receptor as heroin, as morphine, as oxycodone, most people think, well, yeah, exactly. It's just substituting one addiction for another. But this is the training and the teaching points that I make to my patients every single day and to my own colleagues, nurses and other doctors and counselors and the general public. Yes, it binds the same receptor, but heroin acts like this, right? The action of onset is 1 to 2 minutes, but then it wears off after a few hours. The nuance is in the pharmacokinetics. Methadone and buprenorphine bind that same receptor, but it takes hours, if not days, and then it stays bound. That's why they're effective at reducing cravings and reducing withdrawal symptoms. They allow patients to engage in treatment and in recovery. Make no mistake, methadone is a life-saving medication. So buprenorphine, commercially known as Suboxone, Subutex, Sublocade as well, also it binds the same receptor as methadone, as morphine. It's also used to treat opioid addiction, and it can reduce pain. But unlike methadone, it's a partial agonist, binding that same receptor, but it's so strong. Think of a magnet. It binds that receptor, and it'll knock off anything that was already bound. That's why if somebody is actively using heroin right now, I can't put them on right away, or else I'll precipitate withdrawal. So, but make no mistake, this medication is extremely effective at reducing euphoria and helping people, reducing cravings and withdrawal symptoms. And because it's a partial agonist, there's a lower risk of overdose than methadone. Make no mistake, buprenorphine is a life-saving medication. Well, ever since I was a primary care doctor in Boston, I have prescribed this to multiple patients, many of them were veterans. I know we're in a VA hospital right now. I've had the honor of taking care of many, many veterans. I had one vet, he was a special agent. He was in the Marines for 9 years. He was stationed in Panama and really all over the world. By this point, he had severe diabetes, severe pain, depression, and polysubstance use disorders. But I put him on Suboxone, and he came back. This is months later, and he said, "Dr. Roy," and he showed me, "I got something for you." And he was just elated to show me his diploma. He finally got back to school, a training program, got a diploma, got an apartment. And that's just one example. I have countless examples of people who are just like you and me. Something happens in their life, and they end up in the whatever predicament that they're in now. So I want to make sure we're all clear that detox is not the same as maintenance. Detoxification means that a person is weaned off their dependence of opiates by taking methadone slowly. You can take methadone or buprenorphine. But relapse rates are over 90%. So the next time somebody tells you, "Oh yeah, they've been detoxed, they're good. They got 5, 6, 10 days of detox, they're good." They are not good. Relapse rates, that person, just detox alone, they will relapse, they will use, they will die. I'm being probably a little too blunt there, but you have to think of it that way. Detox is not treatment. Maintenance, on the other hand, reduces withdrawal, cravings, increases comfort. I get asked a lot, "Oh, well, Doctor, how long does he have to be on it? How long does he have to be on methadone or bu?" Well, how many times have you asked your patients, "Well, how long does he have to be on insulin? How long does he have to be on lisinopril?" We don't, or how long does this asthmatic have to be on an inhaler, the albuterol? We don't, right? Because we don't stigmatize people with those illnesses the way we stigmatize people with addiction. So my short answer is they need to be on it for as long as they need it, which means as long as they have cravings. Have I had patients that have eventually been taken off? Yeah, but that's because they have come to me and said, "You know, Dr. Roy, my life is good right now. I just have no cravings." So the question we should be asking is not how long do you have to be on it, but rather just tell me, what's the quality of your life right now? What's life like for you today compared to a month ago, 6 months ago? You're back at work, taking care of your family, back at school, have a home, have a job. In other words, if you're living a normal life like us, you may not need to have these medications, but if you do, that's okay too. Make no mistake, maintenance is really the path to recovery. I didn't know that there were so many public health benefits to methadone, reducing HIV, hepatitis B and C. People go back to work. Reduces crime, illicit opioid use by 70%. People live longer. And then here's the key. We're talking about people overdosing and dying of opioids. Opioid overdose deaths reduced by up to 80%. We have lots of data, ladies and gentlemen. We've known this for a long, long time. So a little bit about opioid treatment at Rikers Island. So Rikers, their OTP is called KEEP. They actually began treating opioid use disorder with methadone in the 80s and with buprenorphine in 2016. Rikers was the nation's first and remains the nation's largest jail-based opioid treatment program. funded by the health department, accredited, over 11,000 detoxes per year, and over 4,000 people maintained. So you're all going to hear these myths. I still do to this day. Methadone and buprenorphine just substitute one addiction for another. We talked about this already. If you hear that, this is the response. Methadone and buprenorphine are life-saving medications. They treat opioid use disorder, reduce cravings and withdrawal. They allow recovery. Another myth I hear, well, buprenorphine and methadone, they're more dangerous than other chronic disease meds. One of your chiefs, just when she brought me to the hospital, pointed out the warfarin building, right? The Wharf building. How many of you get paged every day, just not only on Coumadin, but what about insulin? How many of you get paged about insulin, called about insulin titration? Oh my God. I mean, to me, those medications are far, far more dangerous than methadone or buprenorphine. So management of both is actually far simpler than many other chronic disease meds. So, and there are plenty of other myths. I actually have like 3 slides of just myths, but let me move on to some psychosocial therapies that are extremely effective. So, behavioral therapies help engage people in treatment. They provide incentives for them to stay abstinent. They modify attitudes and behaviors and help people deal with the stressful circumstances that come in life. There's many different types: CBT, motivational, adolescent, 12-step. Again, there's a whole list. I thought I'd mention some of the major ones. And then at Rikers Island, they also provided behavioral therapies. The program is called A Road Not Taken. Started in 2008, and structured program, individual, group therapy, creative arts, mindfulness. When I was there, they were providing mindful practice to a lot of the women. Again, 99% of whom had some type of trauma history, and many of the women, I didn't include it in this presentation, but some of the quotes were, wow, I actually feel good for the first time in my life, or it's really helping me to feel in peace. Some of the testimonials are really just heartwarming. So speaking of women, again, ladies and gentlemen, these are all things that I've learned on the job. I published a piece in, I think, the Huffington Post about my experience at Rikers with women specifically. Women are the fastest growing segment of the U.S. Prison population. Over 60% of women in federal prison are behind bars for non-violent drug offenses. Black women are twice as likely to be incarcerated as their white counterparts. Native American women, 6 times as likely to be incarcerated versus white women. About 60% of women in prison are mothers of minor children. Many of them are the sole caregivers. Think back to what I said earlier in the presentation about the collateral consequences. So what's happening to these kids? They did nothing wrong. What's going on here? Right? Prosecutors nationwide have targeted pregnant women accused of drug use, supposedly in the interest of protecting the fetus. So speaking of women who are pregnant, pregnant women who use drugs face highly stigmatizing and inaccurate perceptions from society. Disclosure of drug use makes women vulnerable to discrimination and increased scrutiny by law enforcement or child protection services. In the United States, certain states like Tennessee, some pregnant women who use drugs are incarcerated for fetal assault. But I just told you that having addiction is a chronic disease of the brain. Becoming pregnant doesn't fix that disease. Methadone and buprenorphine are standard of care in treating opioid use disorder in pregnancy, not detox or abstinence. And we talked about detox already. And yet, very few women receive either medication, placing both the fetus and the mother, a woman, at risk if you just detox alone. Very few states offer either medication, only a handful, leaving both the patients who receive the medication in the community and those illicitly using opiates in withdrawal during incarceration, which, as an understatement, is not good. So I would be remiss if I did not spend time talking to all of you about stigma. I know we toss that word around a lot. If you were to put an equal sign here, equal, write the word harm, because that's exactly what it is. Just as the definition, a stigma is any type of attribute, behavior, condition that's socially discrediting. Of the 23 million Americans with substance disorder, only 10% access treatment. Now, if you said to me, oh, Dr. Roy, only 10% of your diabetes patients are getting treatment, that would mean that the other 90% are going blind, getting kidney failure, having strokes, and dying of heart attacks. And oh, I guarantee you I would lose my medical license. That's malpractice. Oh, but for the 10% that are getting addiction treatment, we seem to be okay with that. And I'm telling you, that is utterly unacceptable. Stigma is a major barrier to seeking help. According to the World Health Organization, drug addiction is the #1 most stigmatized social problem. Mental illness, alcohol, number 2 to 4. Notice I didn't say most stigmatized health problem, social problem. So drug addiction is more stigmatized than poverty, incarceration, homelessness. We have a huge uphill climb here. But I invite all of you to practice something, a simple yet effective way to reduce stigma. Studies by my former colleagues in Boston, John Kelly, Richard Sates, and Sarah Wakeman, as well as others, Howard Koh, the former Assistant Secretary of Health, and Michael Botticelli, the former drug czar, wrote just excellent pieces about vocabulary. So I invite all of you, actually, let me just say, studies show that when we use tough, punitive, stigmatizing language, such as substance abuse, you're a drug abuser, you're an addict, cokehead, lush. Studies show, and by the way, when I was at Rikers, correction officers would bring by a patient to the clinic and say, we got a package for you. We have a body, referring to another fellow human being. So studies show that when we use this type of language, patients are less likely to seek help, and they're more likely to perceive discrimination. But healthcare professionals, like all of us, when we hear and utilize these phrases and words, we have less regard for patients with addiction. We are more likely to label them as less motivated, violent, manipulative, and we spend less time in clinic. All of this adds up to suboptimal care. In contrast, studies show that when we use less stigmatizing, more compassionate language, such as substance use disorder, a person with substance use issues, your urine is positive for opioids. By the way, saying that your urine is dirty, that's something that's very exclusive to addiction or a drug use world. Think about when you take care of a patient with diabetes, somebody who comes in with a blood sugar of, say, 800 because they ate, 8 Krispy Kremes in the morning. You don't say, oh, Mr. Smith, your urine is dirty with sugar. Or you don't say you abused donuts. In that case, I abused Ben & Jerry's last night, right? We don't, because we don't stigmatize diabetes the way we do addiction. Your urine is positive. Your urine is not dirty. When we use phrases like this, ladies and gentlemen, patients feel less judged, more respected. It improves the therapeutic relationship between patient and doctor, and people are more likely to seek care, which is the aim right from the start. How many people have heard of harm reduction? Yeah, I see that easily, 50%. That's great. By the way, again, I never learned any of this during med school training, so the fact that you guys already know about this, you're so ahead of the game. This is great. So it's really a set of strategies aimed at reducing the negative consequences associated with drug use. It's a social justice movement that's based on the respect for the rights of people who use drugs. And it's a spectrum, right, from safer use, managed use, to abstinence. Meet people where they're at. And there's many, many examples. I'm sure you already know. Clean needles or syringes, naloxone or Narcan, condoms, care coordination. If you get somebody who's, say, on the streets, if you get them some clothing, some place to stay, legal help, food, they're actually less likely to use. Group and support services, health services. How many people have heard of Insight? It's in Vancouver. I'll be visiting there in July. It's actually North America's first safe, legalized supervised injection facility. They offer a continuum of care, addiction, mental health, HIV/AIDS, counselors and peer on staff who connect their clients to services, lots of services. Over 1,000 visits per day, 300,000 per year. But as you can imagine, this did not happen overnight. It took decades of activism. And some of the pushback, some of the media pushback they saw in the media, some of the headlines, injection sites are not the answer. It's a mobile crack house. This, I don't know if you can read this quote, attracts drug addicts, homelessness, crime, and litter. I've often wondered, where are they bringing, they're not bringing their own trash, are they? I don't know. I thought it was interesting. And then I saw this one quote in an article. We don't give drinks to alcoholics. We don't give places for rapists to rape people. So why are we giving places for drugs? You can just, it's palpable, the stigma, the judgment in that statement. But, and look, if you told me 5 years ago, all right, Lipi, we're going to build a site right there where people can inject the heroin, and I'm like, that's crazy. It's counterintuitive. But as we all practice medicine, we all believe in evidence, right? We have to, everything we do, ideally, is based on data. And the data for safer consumption sites globally is unequivocal. They decrease IV drug use. They decrease overdose deaths. HIV and Hep C goes down. People go into treatment. There is no increase in drug-related crimes. And the key point here, 0 fatalities. You know, I was giving a talk in Anaheim, California last year, and a lady at the back asked me, it was a talk on alcohol and trauma and mental health, and a lady in the back asked me, she said, oh, Dr. Roy, you're so energetic, but can I ask you, what do you do for self-care? And I recognized that the entire audience, they were all addiction counselors, nurses, doctors, and I thought, and many of them were in recovery themselves. And so I now make it a point, because I know that all of us work really, really hard. And we have good days, we have bad days, and it's so important that we take care of ourselves. So these are just a few things that I do. Mindful practice, I meditate every morning. I go to yoga once a week. I actually have a gratitude journal by my bedside. I know this is common sense, but really trying to get more and more sleep, eating regularly and healthy. It could be multiple small meals throughout the day. Exercising, it could be just even 10 minutes every day, drinking enough fluids, and really just do what you enjoy. There's no shortage of fun, amazing things to do here in Madison, and just do nothing. The number of times I just come home and plop on the sofa, you would never believe. And then this is a really key point. Just ask for help. There's no shame in this, particularly if you're a med student, an intern, resident, or even my colleagues as attendings or in whatever field you're in, nursing, counseling, case management, just ask for help. We all do it. So, some really key take-home points. Addiction, chronic medical disease, not a sign of moral weakness or failure. Most people with addiction, once connected to the appropriate treatment recovery services, get better. Stigma acts as a major barrier to care. We need far more addiction prevention treatment strategies. Addiction is costly, but preventable and treatable. Medications are the standard of care for opioid use disorder. Correctional medicine is addiction medicine. Pregnant women with addiction need treatment, and racial disparities in incarceration and addiction care are pervasive. So what happened to my patient Brian? I first thanked him for sharing his story, and I said we're going to work together to get you the care that you need and deserve. I connected him to care, psychiatry, ortho, case management to help him with housing and job. And I started on buprenorphine for his opioid addiction, opioid use disorder. After several months, and now years later, Brian has an apartment. He has a relationship with his son. He is in recovery. Brian's life has a sense of purpose. And if you'd like to learn more about this story, this is a documentary film that was produced by Refinery 29. It's available online. It's called Faces of Addiction. Just a 20-minute story, 20-minute film. Jackie Huntington, this photograph is from that film. I thought she did a really great job telling Brian's story. and my journey as a doctor as well. Lots of references in television, CNN, 13th, Ava Duvernay, excellent documentary film, Rikers, and amazing books as well. Gabor Mate. By the way, the new Jim Crow should be mandatory reading for every American. Chock full of data. Michelle Alexander just such a great job. Chasing the Scream, Dreamland, which I just finished reading, talks about Ohio and black tar. And then lots of great resources, ASAM, CDC, PCSS. If you haven't enrolled in it, it's free to register. Lots of great online learning modules and completely free. By the way, Fighting for Space, Travis Lupick is a Vancouver-based journalist who really documents the decades worth of activism. And by the way, I didn't tell you, but every patient or person that you saw in my slides was one of my former patients. And I'm just, and obviously with their permission, I share their stories and their photographs. And so you feel free to email me, tweet me, anytime you have any questions. Go Leafs. Thank you very much for your attention. And if anyone has any questions, I'm happy to answer any questions or comments. Oh, yes, sir.
Well, thank you for coming to Madison for the wonderful, eye-opening presentation. And thank you for being a diplomat of ABAM and advertising that on your slides.
Yeah.
The slide you had with the addiction treatment, it's important to share the various aspects of addiction outside of substance use,
Yep.
which you did. And I think the next frontier will be understanding what life experience and what trauma does to the brain,
Yep.
and how it does set up for addiction. But I do take exception to your comment that everything below the line of the earth, all of the roots, cause addiction and are universally a cause of addiction. It reminds me of when I was actually I was invited by the publisher to write a letter to the editor of Playboy magazine, responding to the Playboy interview of Dr. Drew before he became famous, where he said all of addiction is a result of trauma,
Right.
and 100% of patients have had trauma. It's not 100%, it's very high, and it's a fascinating area where we're going to learn the neurobiology
Yep.
of what happens with trauma and its association with addiction.
Yeah.
But to say that experience causes addiction, I believe distracts from the reality that 60 to 80% of the probability of addiction comes from DNA, not from experience. And I think we need to understand that addiction doesn't happen except in a subset of people. 90% of people will never have it. And substances are not the problem. The problem is not drugs, brains, and genetics.
So I'm really, really glad you brought up that point. So, and it's a really good one. So yeah, I put up that slide very deliberately because most people don't realize that there's a lot of other environmental issues that result or increase one's risk for addiction. Notice if I never said that these are definitely 100% cause these problems. Most people, if you've got a good life, good support system, you'll never develop addiction. And the other thing about drugs, vast majority of people who use drugs are recreational users who will never go on to develop addiction. But it's not just genetics, because let's use alcohol as an example, right? So a young boy, say born to a father who had alcohol use disorder, he has a 50% chance of developing alcohol use disorder. But there's the other 50. And there's the siblings born to that same that will never develop it. So they both play a role. One of my branches was genetics. I just didn't emphasize it as much. So to say that everyone who has a traumatic experience develops addiction, of course not. But I do want to make sure that everyone knows that there is a strong correlation. Any other questions?
One more
Thank you.
question, then cover the front.
How about you? Go ahead.
I am one of the medicine residents here, and we obviously don't get a lot of addiction training in residency. So I was wondering what you're seeing in other residencies or what you wish you had in your
Yeah, thank you. Thank you so much for asking that. This is a major reason why I'm so grateful to Dr. Lewis for inviting me and for the program, for having this event. We're slowly seeing more residency programs incorporate this. At Bellevue, I gave a training to their primary care residents. They have, I think, a 3-week block on addiction. really it has to really be driven by the ACGME, I think. That's one major way. And then department chairs, some of the pushback we get, though, is that they'll say, well, if we put in one, we have to take out something else. So yes and no, but I do think that it's really, really important that all, not only medical students, but all residents, I don't care what field you go into, general surgery, ortho, they should know more about not only pain management, but addiction, but really all fields. Because no matter if you're going to plastic surgery, dermatology, or pediatrics, you are going to take care of patients who have addiction. You may not be addressing it. You don't have to be an addiction expert, but you have to have some baseline knowledge. And that's more than just one lecture. So it's slowly happening, and we're having more of a movement nationally to get that happening. So, but I encourage all of you to just teach one another and make sure you become self-aware. Thank you.
All right, thank you very much.
Come on.